Okay, hello everyone. My name is Kevin Chung, intensivist and chair of medicine at the Uniformed Services University in Bethesda, Maryland. On behalf of the American College of Chest Physicians, I'd like to welcome you to our webinar entitled Hindsight is 2020, What We Have Learned About COVID-19. This is part 2 of a 3-part series. Today we're going to be focusing on bedside care. We are extremely fortunate to be joined by our distinguished panel of world-class critical care physicians and researchers. I'm going to go ahead and briefly introduce each of our panelists. Dr. Richard Oakler from Mayo Clinic in Rochester, Minnesota. If you could just wave, smile, or nod. Dr. Nida Kadir, Ronald Reagan UCLA Medical Center, Los Angeles, California. Dr. Thomas Zakmany, Cardiff University, Wales, United Kingdom. And Dr. Victor Test, Texas Tech University Health Sciences Center in Lubbock, Texas. Okay, so we're going to go ahead and get started by getting to know our panelists a little bit. I've asked each panel member to introduce themselves and in more detail and talk briefly about their role in the last 8 to 9 months. Dr. Oakler, could you get us started?
Yeah, thank you, Kevin. So I'm Rich Oakler. I'm one of the critical care physicians here at Mayo Clinic in Rochester. Born in New York, came out here for residency, fellowship, et cetera, and have been in the Midwest ever since. So my roles at the Mayo Clinic are as the director of the medical ICU and also as the medical director of the ICU recovery program, otherwise known as the PICS clinic. And so in those roles over the past 6 to 9 months here in Rochester, I've been quite involved with the COVID response. So our medical ICU has become the de facto COVID ICU, and that's required a significant amount of change in the culture and the physical plant and some of our procedures, and I'll be telling you a little bit about that later. My PhD is in physiology. My primary interests in our research realm are in mechanical ventilation and respiratory mechanics, et cetera. But today the focus will be on COVID response. So thanks for having me.
Great, thank you, Dr. Oakler. Dr. Kadir?
Hi everyone, I'm Nida Kadir. I am one of the pulmonary critical care docs here at UCLA. I am the co-director of both our medical ICU and our COVID-19 response, and thus have been heavily involved with all things COVID over the last several months and aged approximately 100 years. So I'm looking forward to sharing with you guys a little bit about our experience here.
Great, thank you very much, Dr. Kadir. How about Dr. Zakmany?
Hi, I'm Thomas Zakmany. I'm an ICU consultant in the Grange University Hospital in Wales. I have been involved with the COVID response both on the hospital side, and I happen to be the clinical lead of the All Wales Critical Care and Trauma Network during the first wave. So I have been heavily involved in coordinating the nationwide response and how the ICUs were stepping up and then stepping down during the first wave and now in the second wave. Our new intensive care unit, which is relatively small in US standards, have got 24 beds, and we've got a steady stream of COVID-19 patients. My other interest is research, and my conflict of interest for this talk will be that I'm the principal investigator locally for both the recovery and the REMAP-CAP trials. So you will probably hear something about those drugs trialed in these settings. Thank you.
Thank you very much. And last but not least, Dr. Test.
Howdy. Thank you to Kevin and to Chest for allowing me to participate. I am the Chief of Pulmonary and Critical Care at Texas Tech in Lubbock. Before this, I was the Director of the Pulmonary Vascular Disease Program at Duke University. I'm also on the Board of Regents of Chest and the Education Committee for Chest. and also the Training Transitions Committee for CHEST. My role here in Lubbock is the director of the medical ICU. I've been actively managing COVID patients on a near daily basis for almost 9 months. That has also involved coordinating with our colleagues and other intensive care unit specialties, neurologic critical care, and surgical critical care, as well as we developed our response and management of these patients. And so thank you again for having me.
Great. Thank you, Dr. Test. So now we're going to go ahead and go around the horn and get a general overview in the assigned respective topics. For the audience, if you have questions during each of the panelists' sort of overview, feel free to type in the question in the comments or Q&A section. I will be monitoring that, and anything that will add to the discussion, I will go ahead and ask immediately at that point. And if not, we can just save them for the end. So I'm going to ask Dr. Oakler first to give a general overview of clinical management of COVID over the last 8 months. What things have remained the same? What things have changed? In general, can you talk about clinical management in general? Oh, I think you're muted.
Thank you. So quite a few changes, obviously, since this pandemic started. I'll talk about a couple of both physical and cultural changes that we've really had to address here, at least in Rochester, with the caveat being that we were a little bit geographically isolated on the first wave, and I think that gave us some advantage, actually, when looking at all of you and all of the changes and experiences that you were having. It gave us a little bit of time to prepare for things coming down the pike. And when I talked to that end, it was very easy to stick to our guns and really focus on what we know works best on these patients, especially in the first wave, because we weren't really overwhelmed. The system wasn't overwhelmed. And so our focus really was to continue high quality supportive care and keep, most of our standardized approaches that we use in place without having to go to kind of a contingency plan or change of location that might impair some of the kind of multidisciplinary team that we use to treat our patients. When we talk about that, though, a key is team dynamics. And one thing we found early on, in fact, probably just in the first couple of days of the pandemic, were just some of the team dynamics related to trust and what information we could actually reliably use and use to change our practice and implement some of the methodology we're using going forward. And so that really surrounded things like PPE, the rumors out there, what was working on the PPE front, where it was this an airborne condition. And I know maybe I'm stirring up some controversy. I know in the Twitterverse, there's certainly still all sorts of talk about what the actual AGP guidelines might be and what PPE is best. I can tell you we learned some lessons from our high consequence infectious disease team that I'm also a part of. When we trained there, really the biggest problem we had was in the doffing process. That's where we were contaminating folks. And so we said, hey, you know what? We need our maximum PPE, but we need to keep it to the maximum that's the minimum and not overly complicated. So we knew things like headgear and these very long head-to-toe gowns were hard to get in and out of. And so we actually minimized it to your standard kind of modified contact isolation with the use of like most are using gowns, gloves, N95 if there's an AGP, otherwise a surgical mask, and a face shield. And so with that, we've really had no healthcare worker infections in any of our actual COVID units. We have had several infections that have been identified through contact tracing to have occurred outside in the kind of in the wild, so to speak, but not directly related to patient care. So we're pretty confident on that. And it took quite a bit of town hall and information sharing type venues with our IPAC folks, with the ID folks, me in my role as the medical ICU director, to really kind of target and address those kind of rumors that would circulate over and over. So again, I can't emphasize, we're going to talk about things like increasing our ICU capacity, et cetera, but I think really the first thing is that team building and to get everybody on board and confident in the fact that what we're doing is effective and that we're keeping each other safe and protected. And so that was what I really envisioned my first role as. And I think we've been pretty successful that way. Again, I think, the key is we know the things that work, we know the things that don't. Dr. Kadir will probably talk about some of the changes in mechanical ventilation and Dr. Test maybe with the VTE, et cetera. There were lots of wild rumors and things that you could read on the internet and all over the place that kept coming back to us. Should everybody be anticoagulated? Should we have TPA given to certain folks based on D-dimers, et cetera. And again, I think we stuck mostly to our kind of standard approaches, our high quality supportive care, and we've done very well with that. Obviously, as we learn more through the data that's coming down the pike, we've made some changes. So for instance, we hadn't been using steroids on most folks, but after the steroid data in ventilation, we started to do that. The remdesivir and some of the other study drugs have been used in certain patients, but again, not sort of blanket approaches. And we've actually utilized our ICU COVID ID team to help direct that. So just recently with some of these going on EUAs and et cetera, there has been a change to that. We had every COVID patient having an ID ICU consult, and that's changing a little bit now. Again, we could talk about things like convalescent plasma. I think I won't focus on specific therapies, and maybe we can get into that in the discussion. But again, we were a bit conservative with how we applied those, and again, stuck to things we know worked well. So, our ventilation strategies, our early mobility, trying to stick to the A through F bundle, et cetera, et cetera. Other things that change. So physical plant, our beds capacity normally in the MICU is 32 beds. We have expanded that now to 60 beds. And with that comes quite a bit of challenge, as you all know. So we're averaging now about 30 to 35 COVID patients per day in our ICU setting. And so that's more than our entire MICU had been before. So we've had to employ and utilize team members to their maximum ability. So fellows became subconsultant teams. APPs have had a little bit of expanded practice to offset some of the need for ICU. We've had some culture changes at Mayo. So I would say, and the folks on the webinar that may have trained or know folks at Mayo, we always say there's the right way, the wrong way, and the Mayo way. There's some things we just do for cultural reasons that are hard to change. But we've really started to try and get folks to use high flow on the floor. So we're now letting folks start high flow nasal cannula on our floor services. And we're starting to look at maybe BiPAP or CPAP on the floor. I know to a lot of folks on this call that probably sounds funny and you're already doing that, but for us that was actually a big change. And again, it gets back to the trust and the team dynamics and backing things up with monitoring and RRT calls, et cetera. To that end, and maybe I'll stop after this, is we've really started to employ our telehealth presence that we've always focused outside of our institution and into our health system. We really turned that more inward now, and we're helping to offset some of the workload and staff those team members that we're talking about. So a subconsultant COVID team, which would be a fellow really in the lead with consultant oversight through the telehealth, has worked fairly well. And also the telehealth folks and remote patient monitoring, kind of keeping an eye on folks out on the floor that we're starting high flow on and BiPAP on and things like that. It helps again to reassure them that they're not alone out there. This is something new for them, but there's someone looking over their shoulder and keeping them safe and escalating care when we need it. And so to that end, we employed what we call a kind of a system-wide critical care officer of the day, which coordinates with the state with the ECMO group and liaisons for patient flow for decision-making on some of these tough cases of resource allocation. And finally, the remote patient monitoring has helped us get people out of the hospital a little bit sooner than we normally would be comfortable with. And they're actually followed by telehealth and a pulse oximeter and a vital sign monitor, basically, that reports in twice a day to the remote patient monitoring team. And in appropriate patients, they actually then, when they graduate from that program in a week or two, if they're home and continue to improve, the appropriate people who may have a higher risk of PICS actually then get handed off to us in the MCIRP or the ICU recovery program for further follow-up if necessary. So I think, that was a lot of things. I probably talked more than I should have, and I'm happy to answer questions, but those are just some of the general changes that we've had to make with a fairly large and sometimes lumbering system. So I'll stop there. Thanks.
Yeah, thank you, Dr. Oakler. You mentioned how your PPE posture sort of got tweaked over time. Has that changed with regards to your PPE posture during aerosol generating procedures, mainly intubations and bronchs, et cetera?
Yeah, I think the interesting thing is actually what constitutes an AGP. So obviously the bronchs and the intubations are the easier ones, but that really has been quite a sore spot or a point of disagreement between some of the providers. And again, we've tried to look at the data as best we can. So for instance, a patient on a ventilator with a viral filter in place, is that a medium, low, or high risk AGP? Technically, sure, if the circuit is closed and the patient's paralyzed and there's no disconnection, maybe I'd say it's a lower risk. But unfortunately, a lot of times these folks pop off or there requires more suctioning than inline Ballards can do or inline suctioning. And so how do you decide on that? And then, to get into the complexities of what is your airflow monitoring? I've gotten more into engineering and building engineering than I've ever really wanted to in the past few months, where we know, certain rooms will turn over the number of cycles in 20 minutes, some in 60 minutes. But either way, I think we focused it down to having two sets of PPE. So you have the AGP PPE and the non-AGP PPE, and really the difference there being kind of a full face shield and an N95 versus a surgical mask. And again, we've done quite well with that. The ones that I think I've always been a little bit struck by, and I know there's a tendency to want to cover every part of your body, but really, again, from some of our experience, at least internally, with head covers and the really long gowns, that's where we've tried to avoid those things, because we really have seen more doffing contamination there than probably the benefit of any further protection. Obviously, as everyone on the call knows, the virus is probably getting in your eyes, nose, and mouth, and not through your hair. So again, that's just been our approach. I know there are different approaches to it, and interesting what other folks say. Yeah. So
face shield and N95, that's your aerosol generating posture.
In addition to the, so gown, gloves, and then face shield and an N95. Yes.
But not PAPR.
So an N95 or a PAPR. So if you're fit tested, we've been seeing a face shield and a N95 equivalent to a PAPR.
Okay. Very good. Thank you for those thoughts. I think we'll move on to Dr. Kadir. Can you give us an overview of respiratory support and how you've sort of managed that over the last 8 to 9 months, and how that's evolved?
So I think Dr. Oakler alluded to this. Emotion played a large role in some of our early response. And by we, I mean like the collective we, at least in the US. I think that ratio of data to emotion played a substantial role in our practices, and thankfully that's evolved over time. There's a lot of fear, I think, driving some of these initial practices, which is understandable considering we were hearing these really sky-high mortality rates reported in some of the early case series. While we emphasized evidence-based management at our institution from the beginning, I found myself doing a lot of talking people down from the ledge. Oh, my buddy gave TPA to a bunch of his patients. Should I be doing that too? Should we be anticoagulating everybody? So there are a lot of questions like that, and basically nightly almost calls addressing things like that, all of these stories, all of these fears. And now, sadly, we have over 15 million cases here in the US, and COVID's become more of a routine part of care in the ICU, which I think has resulted in us treating this in a more rational manner, and in the more similar manner as how we treat other forms of respiratory failure. So, for example, there are a lot of debates initially about pre-intubation management of patients with COVID and hypoxemic respiratory failure. Should we use high flow? Should we use non-invasive? Should we not use any of these and just intubate early? And at least some of these questions were driven by concerns surrounding aerosolization and infection prevention and just avoiding emergent intubations in these patients in general. But when you think about it, the fact that we were even considering not doing things like high flow was a deviation from what we've done for other forms of respiratory failure. There's a substantial body of evidence suggesting that high flow may indeed be beneficial. The Flora-Lee trial in the pre-COVID days found that the use of high flow is associated with decreased mortality, and some subsequent meta-analyses have found an association with decreased rates of intubation. And more recently in the COVID population, there's some evidence that it may be associated with decreased rates of intubation. So, I don't know for certain that this is the case, but my sense is that we are all using high flow more frequently than we did initially. Again, this, to my knowledge, has not been assessed systematically, but at least anecdotally, this seems to be the case. One thing that I found a little annoying about this was the lay press coverage about high flow, talking about it as though it's like this new innovative thing, which, it's not. We all know that. And, with that coming like almost this vilification of ventilators. And, a lot of questions both among us as healthcare professionals and also among the lay press came up about when do we intubate? Are we intubating too soon? Are we intubating the right people? And I suspect that over time, intubation practices have changed as well as we've gotten more comfortable with this disease and more comfortable with PPE. Rates of intubation have been quite variable, at least in terms of what's been reported in published cohorts, anywhere from 29% to 90% of ICU patients. And now we don't have a lot of detail about why this is so variable. Does it reflect resource allocation? Like in some places where the hospital is so busy that they could only bring intubated patients to the ICU? Or did it actually reflect differences in actual intubation practices and criteria? We don't know, and we actually, unfortunately, still don't know. Not a lot has been published about intubation practices at specific institutions. But I do suspect that the threshold to intubate has changed, or at least more thought's been given to this. I remember early on hearing that some centers were intubating patients who needed more than 6 liters nasal cannula. And, in retrospect, that sounds kind of extreme. I don't hear that very often anymore. And I hope I don't, I hope to not hear it very often anymore. Because we do know, of course, that even prior to COVID, there's no real set cutoff in terms of level of hypoxemia at which to intubate. Our decision depends on a lot of things: the work of breathing, the patient's clinical trajectory, presence of other organ failures. It's not a simple or straightforward decision. This has, I don't think, become any more clear during the COVID era, but I do think it's fair to say that there's nothing that we know thus far to suggest that intubation timing should be too different in patients with COVID compared to patients with any other severe respiratory illness. I think, beyond that, in terms of ventilation, that's also been an area of fierce debate. I think this is a little bit more settled now. We all heard the this is not ARDS theory circulated quite a bit early on, much of it due to some anecdotally reported high lung compliance observed in some cases, with the publication of subsequent cohorts showing compliance ranging more like in the 20s to 30s. And a lot of back and forth on Twitter and in journals about this argument. Is it ARDS? Is it not ARDS? I think we eventually circled back to, yes, this is ARDS. In terms of managing ARDS, even if there are different phenotypes of ARDS, which there likely are, we still don't know of anything better than low tidal volume ventilation in terms of what to use to support this patient population, in spite of any potential heterogeneity. And by better, I mean, we don't know of a management strategy that's any better at saving lives. Until we do, I think deviating from that practice of low tidal volume ventilation is at best improvisational and potentially harmful. After a whole lot of debate, I think we're kind of back to where we began in terms of ARDSNet, which has now been around for 20 years. Again, like I mentioned about high flow, about intubation practices, while I suspect that practice has changed to reflect what I'm saying, that we're now more comfortable saying that this is ARDS and ventilate it like ARDS. This has not yet, to my knowledge, been studied systematically. So it'll be interesting to see if this is actually the case. But anecdotally, this does seem to be what I'm noticing in terms of COVID management. So, ultimately, what did we learn? What's changed? Maybe just that everything old is new again, and we had a lot of things in our toolkit all along that maybe we weren't taking advantage of early on.
So Dr. Kadir, could you talk a little bit about your threshold for proning patients, and how long do you prone, when you stop proning, et cetera?
Sure. So for mechanically ventilated patients, I will prone patients when they have a P to F ratio of less than 150 on 50% FiO2 or more. And this is assuming I've, made whatever vent changes, optimized them on the vent as best I can. And then we will prone for 16 to 18 hours a day. Sometimes longer, depending on the patient's response to proning, sometimes not quite as long, depending on, any complications that might develop from proning, like facial ulcers and things like that. In terms of when to stop proning, I will usually stop when either the patient is not responding to proning in terms of there's no, there isn't benefit in terms of oxygenation or driving pressure or anything like that. Or I will stop when their P to F ratio improves to above 150 on 50% FiO2 or less.
Got it. And also, could you talk a little bit about how your outcomes have evolved over time? Has it remained the same generally? What is it compared to other types of ARDS? We can all recall reports of mortality being really high if you go on mechanical ventilation. Is that true at your center?
So the last time I ran our mortality was a little while ago, so these might not reflect the most up-to-date numbers, but our ICU mortality for COVID has been around 20%. It's been a little higher in patients who are mechanically ventilated, probably between 20 and 30%. So, in large published cohorts of ARDS, we see that mortality rates are up to 50% in severe cases. So while I can't say I've directly compared our non-COVID ARDS outcomes to our COVID ARDS outcomes all that recently, the mortality rates that we've seen for COVID are in line or, maybe even a little bit better than mortality rates for ARDS that have been reported in cohorts prior to COVID.
Thank you very much, Dr. Kadir. That was excellent. So Dr. Zakmany, you have the privilege and the tall order of reviewing pharmacologic therapies in COVID. We could probably talk 2 hours on this topic alone, but you have 5 minutes.
Yeah, thank you very much. And I will try to stick to that 5 minutes. And it was a very nice introduction by Dr. Kadir that we have come to the conclusion that this is actually ARDS. And I think we are coming to the conclusion that COVID-19 is actually viral sepsis. So we will have to look back and with the benefit of 2020 hindsight, I think we are looking back our treatment strategies which we started to use at the beginning, especially in the UK, as somewhat suspect. And what we have learned is that yes, we would like to have source control, but the repurposed drugs that we were trying to use, they didn't provide the source control, and a lot of the hype of different therapies, which this will work, that will work, that will stop the transmission of the virus, that will stop the progression of the disease. We haven't seen any real results. As I said, I have been heavily involved both in the recovery and the REMAP-CAP studies. And when we set them up in March in my hospital, I must say that my biggest concern about the drugs that we were trialing in the recovery trial, which was hydroxychloroquine, Kaletra, azithromycin, and dexamethasone, was actually with dexamethasone, because that's where we had relatively good quality evidence that it might hurt patients in viral sepsis. The other three drugs I was completely okay with, because I thought that they probably won't hurt, but dexamethasone could hurt. And then that was the drug which actually showed to be beneficial, and one of the three drugs which are actually licensed to combat COVID-19. In the UK, because we had a very cautious and sort of coordinated response to the pandemic, we haven't had the luxury of using a variety of drugs. So we have always stuck to what we knew was working. And even when the data started to come out, for instance, the ACTT1 study showed that remdesivir might be beneficial. It is still not a mainstay of therapy in our institutions, mostly because it is more difficult to get hold of, but also there is a general reservedness in our UK colleagues that we don't need to use all the drugs which are available. There are, fortunately, the scientists are working hard, and there are always new approaches. And this is what you can see in the proliferation of the different immunomodulators, which I'm not going to go into, because the sepsis work in the last 25 years showed us that it is really difficult to find one single mediator, which if you block, then you will have a better results. There are some really interesting and hopefully encouraging results with immunomodulators in REMAP-CAP. So tocilizumab might be something that we will be looking at using more frequently. But we just need to wait for those results. And I have seen in the Q&A session, and that was one of the questions which the audience sent in, that what about ivermectin? And that is a question which has not been answered. It has been used extensively, especially in the third world, especially my Indian friends and colleagues. They are using it in the outpatient setting, less so in the hospital setting. There are a number of well-designed randomized controlled trials looking at whether this drug could be useful, but the data, apart from the odd publication in a good journal like Chest, is still sketchy. Whether that this can help in hospitalized patients. My hunch at this moment, and the available very anecdotal data, is probably showing that it might be helpful in the outpatient setting before patients are coming into our healthcare systems. I could go on for a long time about all the other drugs, but I'm just looking at the the time. And I think I will hand over to the next speaker, and then we can have some Q&As later.
Before we do that, can I ask very briefly about remdesivir in the UK? What are your thoughts on remdesivir?
So remdesivir was only available on a compassionate use, and it's still only available really on a compassionate use in the UK. So we have used it in a trial setting, and I haven't given it to a single patient before the ACTT1 study was published. Since that publication, my colleagues started to use it on the respiratory ward, but not on the intensive care unit. And our agreement is that if it has been started, then we will continue. But the randomized control trial and also the solidarity, which has got its own flaws, doesn't seem to be pointing towards a lot of benefit on patients who are mechanically ventilated. So we are definitely not using it as standard care.
Thank you very much for that overview. For the audience, I know you have a lot of questions. We're going to go ahead and hold those until we hear from Dr. Test. And please, we'll try to get through as many as possible. So Dr. Test, you're up. And could you give us an overview of your approach to venothromboembolic complications, prevention, et cetera, et cetera?
Sure. Well, as Dr. Kadir mentioned earlier, this approach keeps evolving. And during the summer, of course, we had two guideline statements from two large societies, including CHEST and the International Society for Hemostasis and Thrombolysis, or Thrombolysis and Hemostasis, on prophylaxis, not in therapeutics. And like most things with COVID, there have been a lot of hypothesis about what to do. And I think if someone mentioned that you could prevent DVT by putting peanut butter on your ears, that people would have tried that already. We do know several things. The first is that the coagulation tests that we typically use on, including the D-dimer, the PT, and the PTT, are abnormal in these patients with a great deal of frequency. They regularly have elevated fibrinogen, and they have decreased platelets. On top of that, they have a significantly increased incidence of VTE. There have been in the thousands upon thousands of studies and or papers published on coronavirus in the last 11 months, I would guess about 15 to 20% of them are on venous VTE. And so the incidence of VTE in the ICU population ranges between 15 and 80% on these case series. On average, it's around 30%, even in series where they had 100% compliance with pharmacologic prophylaxis and even systemic anticoagulation. What we've done has changed over time. Initially, we started off with the standard thromboprophylaxis. When the early news came out from China and from Italy about the improved outcomes with systemic anticoagulation, and because we had significant numbers of patients with an increased number of patients with myocardial infarction as well as pulmonary embolism in the first couple of months of patients we saw, we started anticoagulating people more aggressively, really monitoring originally a higher level of intermediate dose prophylaxis as well as mechanical prophylaxis in each of these patients. Then full anticoagulation in the setting of known VTE or with evidence of progressive hypoxemia and particularly increased dead space ventilation. We typically were using enoxaparin and 81 milligram aspirin. In June and July, when the guideline statements came out, they advocated actually against routine anticoagulation of these patients, and the increased sort of intermediate dose prophylaxis was there was discordance between the two societies on what to do. We have then therefore continued with the increased prophylaxis. One of the practices that was advocated very on was to use the D-dimer to guide you. And when patients' D-dimers began to climb, that you would anticoagulate, step up their anticoagulation, that you can then follow them with the antifactor 10A level, because there's an identified increased risk of heparin resistance. And we were doing that very extensively for a while. We're still following the D-dimer. I think on average, we have more patients anticoagulated than without clear proof of VTE. I think, though, despite that, we haven't had any identified cases of VTE in our population, but we certainly see people, despite anticoagulation, develop increasing physiologic dead space with increasing CO2s despite adequate minute ventilation, suggesting microvascular thrombosis, which of course is a whole other issue here. But as a consequence to the statements from the ISTH and the ACCP in the chest, I backed down on that somewhat, and I haven't really seen any significant aftermath from that. I think the jury is still out, because every week, every month, there's a new study coming out suggesting that systemic anticoagulation actually does have some benefit. Now, they're not randomized controlled trials. Those trials are still in progress, and so we await those trials with great anticipation. I think for our center in particular, once a patient gets to the ICU, they, as Dr. Kadir mentioned, almost all of our patients have severe ARDS. I mean, they are not, but for them to get to our ICU, they have to have that. And so thus transporting them and for imaging is also problematic. And so we rely a lot on ultrasound and echo to guide us for sometimes for presumptive diagnosis of VTE when we have climbing D-dimers and we have clinical pictures that match that. I wish we didn't do that. I wish we could procure imaging on every patient to look for large vessel VTE, but we can't. And then of course there's the whole question of how do you image for small vessel or microscopic thrombosis, and the answer to that is you really can't. This picture continues to evolve, and we will hopefully have some definitive answers about systemic anticoagulation, and also the question that was brought up earlier about TPA, because that has been shooting around the social media and the internet for a good while now with not very much proof to support it.
So thank you, Dr. Test. What about your screening strategy? Are you screening routinely with ultrasound, or waiting for a specific D-dimer level, or just wait until you have something clinically symptomatic?
Well, we've been screening every day with D-dimers. We follow that and follow the platelet count when we're not I think also, we again look at the sort of rough estimate do we think the physiologic dead space is that increasing? We use ultrasound at the bedside clinically quite regularly, but the formal diagnostic ultrasounds for VTE, we don't get them routinely unless we have a reason to suspect that. We'd probably adjust our anticoagulation more on the basis of the D-dimer, although very frankly, the chest guidelines were quite explicit in stating that was not recommended. And, I think we've been reassessing that approach for the last couple of months.
So very good. Thank you very much to all the panelists for giving that general overview. We have the next 15 to 20 minutes where we'll field a variety of questions. And so please bear with us. If you have additional questions, please feel free to either enter it in the chat or the Q&A. The first that I see here, is there any evidence of continuing dexamethasone for more than 10 days? And then there's a related question from the registration. Is there room for varying steroid dose depending on severity of disease? Who wants to take that one?
Well,
Go ahead.
Sorry. I will take the first one, the whether there is any evidence for 10 days. At this moment, there isn't a very robust evidence for that. There are only a few studies which looked at longer steroid therapy, and it doesn't seem to be that longer is better in that sense. And we are all a bit wary about the potential complications. And the varied steroid dose, I will let Dr. Nadir to comment on.
I'm just going to kind of reiterate what you just said. We don't have much evidence for the use of steroids beyond 10 days. I think it's important to keep in mind, though, that longer durations of steroids are more likely to be associated with adverse effects. In the recovery trial, steroids were discontinued at either 10 days or at time of hospital discharge. So in some patients, they were discontinued earlier, which I will say I've done in my practice in people who are clinically improving from the COVID standpoint, but perhaps having adverse effects like refractory hyperglycemia. That's come up a bunch of times. So in terms of longer duration, I guess it remains to be seen, but not that I'm aware of yet.
Great. Thank you, Dr. Kadir and Dr. Zekmany. So sticking on this topic of steroids, how about inhaled steroids? Is anybody using inhaled steroids in the ICU or even ED patients?
Yeah, I can address that. So there was a great deal of enthusiasm from the city down to the south of us, a physician who has been using inhaled budesonide with a 100% cure rate for COVID. So we get that question an awful lot around here. We do not routinely use inhaled budesonide or any other inhaled steroid in the treatment. Now, occasionally we have patients who have significant cough, and I will say that at least anecdotally that seems to help the cough in some of these patients, even on the mechanical ventilator, but we are not using it therapeutically with the idea of treating COVID at our center.
Thank you for that answer. I always get a little bit suspicious when somebody claims 100% effectiveness. And so I'm glad to hear that. Sort of on the same topic, maybe related, how about aspergillus? Have you seen any cases of aspergillus in your centers? Anybody?
I have. I don't have a good sense of how common it is. I have seen a couple of fungal infections post-severe COVID. We know that this occurs after influenza, and I think it remains to be seen how frequent this is post-COVID. My sense right now is it's probably not terribly common. The cases I did see were earlier on in the pandemic when there was a lot more use of IL-6 inhibitors and sometimes combining those with steroids. So immunosuppression, may play a role in this, but we will see. I know there is somebody working on compiling a case series on post-COVID aspergillus.
Okay, thank you. I think we're still sticking to the topic of steroids. There seems to be a lot of interest. So solumedrol versus dexamethasone, and then somebody commented that they thought the dexamethasone 6 milligrams might be too low. Any comments on this?
I'll take that. The dose, again, it is really unclear that what is the correct dose, and quite frankly, we don't know. When you look at the published evidence, it is probably somewhere between 6 milligram of dexamethasone to 10 to 12 milligram dexamethasone. That might be the right dose, but we don't exactly know. And again, I just keep coming back to that. We don't have any evidence that more is better in this respect. What we have seen and we continue to see repeatedly, and going back to the previous question a little bit, is that higher dose steroids have been advocated by our ECMO centers in those patients who were not responding to therapy, but very much later in the course. So we are talking about 2-3 weeks in the course with significant fibrotic changes on the CT scan. That's where we have turned to higher doses of steroids. And currently there is no clear data in our hands. Sometimes it works, sometimes it doesn't. So I don't have a clear guidance for that.
And do you at all use inflammatory markers to decide on dose of steroids, increasing it or not? No. Okay.
Yeah, I would agree with Thomas on all of what he just said. I think one of the big issues we've seen is with steroid, and to Dr. Kadir's point, is especially in the ICU recovery clinic, the patients who've recovered, some of them definitely have had more of the neuromuscular weakness issues with that. The other thing is, from co-infection standpoint, at least in our experience, two comments, I suppose. From the mortality standpoint, we've been tracking through our almost 300 ICU patients now with COVID. We really, as I alluded to earlier in the talk here, we really didn't use many steroids at all at the beginning, taking more of the approach, some of the data from flu, et cetera. Now that we've started using them, I can't tell you that 6, 10, or 20 milligrams of dexamethasone has made an inkling of difference in our outcomes thus far. And then I would say from co-infection standpoint, we continue to see staph and strep being our most common co-infections. And I think the others really are occurring at kind of, the usual rates we would see incidentally found more than, something associated specifically with COVID. But again, that's just a single center experience.
Great. Thank you very much. Just to pivot a little bit on another topic, there have been a couple of questions about BiPAP. So what percentage of patients do you think require BiPAP? Do you go from high flow directly to intubation, or is there a significant percentage that go on BiPAP? And if you do have patients go on BiPAP, how long do you keep them on BiPAP at 100%? How long is too long?
I can take that one. I don't use BiPAP very much in this setting because COVID is not something that gets better quickly. And for the most part, I try to avoid BiPAP in acute respiratory failure if I'm not in a setting that the patient could, have a relatively rapid turnaround, like, CHF, volume overload, things like that. I have used it as a pre-oxygenation method. I have used it in patients who are chronically on BiPAP at night, certainly. But I would say my use of it overall is on the low side. I will also add to that, though, that we don't have access to helmet BiPAP. So I wonder if anybody else on the panel does and what their experience with that has been.
Great question. Anybody else on the panel care to comment?
Well, first I would comment, I guess, from at least, again, here, what we've done is the thing we found is these folks really do like flow. And so we've actually are not going even to nasal pendants or non-rebreathers. We go right from, say, 6 liters nasal cannula to high flow. They do seem to respond when we have to transport, especially from the floor, just 5 or so of CPAP tends to improve some of these folks. And I think that gets to the lung compliance question. And are some of these people being over-peeped? But I think for the most part, we've stuck more with high flow. I have to say, and this may be heresy, we've really stuck to the same approaches we've used on all of our respiratory failures. So we haven't let people, you may have seen my eyes get a little wide when you mentioned something about people on BiPAP at 100% for, I don't know how long you're leaving them on that. I guess we have not done that. We've intubated. I don't think there's an early or a late intubation. There's just an appropriate time to intubate. And so maybe we're fortunate to have the resources to do it, but we've been intubating, folks, we get concerned when they're above 70, 80% for quite a bit of time. So.
Okay. Sticking with the topic of mechanical ventilation, can anybody comment on the use of APRV, airway pressure release ventilation, versus ARDSNet?
Hot button issue. I can let Dr. Kadir talk about. This is a big debate within our group. We have several folks from the military who've used it a little bit more extensively, and there's been debate. I guess I don't have a specific, paper or anything I can point to. I've always thought that you should use the mode that you know the best and can apply appropriately, and to tailor to the respiratory mechanics. But I'll let others comment.
I think from from our point of view, we haven't been a big users of APRV. I can see that this COVID-19 pandemic could give us some answer whether APRV is actually that much better than low tidal volume ventilation. But we like most of the, I think most of the others on the panel, we just stuck to the guns that we knew were working, and we followed the low tidal volume strategy with not too high PEEP.
So being in the military and being an advocate of APRV, I can tell you, I mean, if you're there bedside 24/7 for weeks at a time, and you can do APRV and RTs are all skilled and you're doing it consistently and doing it right, I could see where it's beneficial. But my experience has been, you put somebody in APRV, the next shift somebody comes along, switches them back to low tidal volume, and then you go back and forth, you do more harm than good. So I've completely abandoned APRV in my practice.
I would just, to add to that, I think that the point of you should use the mode that you're most comfortable with makes the most sense here. I don't think there's anything intrinsically wrong with APRV if you know what you're doing. But the problem is, one thing that you just said is the next shift, somebody changes them back to some other mode. And I think that's because a lot of physicians, while they hear APRV and they think it sounds like cool and new and exciting, don't actually know the best setting in which to use it. Another caveat to APRV is sometimes you can end up giving your patient can get very high tidal volumes if you're not vigilant and you're not keeping on top of that. So I don't think there's anything wrong with using it, but I think that a lot of people unfortunately lack the experience and expertise in order to use it correctly. And we should remain humble in those circumstances and stick with the things that we know how to do well.
Great. Thank you very much for those comments. We do have another question that is a little bit of a different topic: anticoagulation, prophylactic anticoagulation post-discharge. So what is your practice with regards to, as patients are leaving the ICU or getting discharged home, are you sending them home on anticoagulation?
Well, yeah, I'll take that one. So the CHEST guidelines and the International Society of Thrombosis and Hemostasis are a little bit at odds on that. Not terribly, but a little bit. The ACCP doesn't recommend that routinely, but selection on a case-by-case basis, which I think is probably what is almost undoubtedly what we're doing here. The Society of Hemostasis and Thrombosis really advocates, again, a decision based on the patient's underlying risk factors. Every one of our patients, I don't see anybody when they're being discharged from the hospital. I only see them pretty much in the ICU. So I can't tell you what my practice there is because I don't have one. But I tell you that's what happens in our hospital. And I think that, again, any blanket statement about how to approach these people is probably not going to be appropriate. I think you take it as the guidelines suggest on a case-by-case basis based on the patient and what their wishes are, the risk factors for bleeding, which I think are often underestimated in this cohort. And then you look at their risk for thrombosis, and then you make a decision based on that. The two societies do suggest that it be a finite period of 30 days to 6 weeks if that's done.
Great. Thank you very much. I think we just have time for a couple of more questions, and I'll just take the liberty of maybe going around. Convalescent plasma in the ICU late in the game, yay or nay?
I can comment as a center. We've used some convalescent plasma. The data is mixed. We've had mixed results. There's no strong advice either way. I don't know if Thomas has other.
The current evidence and our own experience points that if you give it by the time the patients get to the critical care unit. And in our center, that means that they are at least, especially in the second wave, they are at least 14 to 16 days into their illness. Then it doesn't really add much to the rest of the therapy.
Okay. What are your feelings on tocilizumab?
I think Tomas should take that question because Remap Cap has issued some teasers, and I'm dying to know.
Works great for CAR T neurotoxicity.
Yeah. So we have heard that the interim analysis showed that it might be better than standard care. So currently, all our patients and every single patient who is on our ICU will get randomized into Remap Cap. They will have some sort of immunomodulators if they are eligible for that domain. It is still a really big question, and I think 27th of December, so early next year, we will have some data on that, in what way tocilizumab could be beneficial, because it could be that it helps to reduce mortality, or it could be that it just helps to reduce the shock state in certain patients. But I've got a good feeling about it, but I don't know how good that feeling will be at the end.
I think there was a New England Journal paper came out today that showed no difference, but only 230 patients or so. So final question for the panel. I noticed, and I was pleasantly surprised that all of you were on MedTwitter. Overall, how does the panel feel that social media has helped or hurt the management of COVID?
I think it's done both. And I go back and forth with my either loving Twitter or hating Twitter. It does help you keep on top of, what is new that's come out, what's been published in the last few days, because the rate of information dissemination has been just out of this world in this past year. I think you have to be careful in terms of what you believe on Twitter, of course. I think where it's very useful is, where your colleagues might post a new article, or the PI for a big study may post their take on it. I think it's incredibly useful in that regard, and you get to interact almost in real time with these folks. But it's, you have to be cautious to not get lost in the mud, whatever that saying is, lost in the woods, whatever, you know what I mean.
So if I can add, I'm an avid Twitter user, and I actually in the last couple of months used Twitter less and less. I read a lot, but I haven't posted that much compared to the previous months. And I would go with what Dr. Kadir just said, that if you've got trusted colleagues and then you created your own little trusted echo chamber, then it can be extremely useful. But if you do open out to the wild and then you dip your toes into the stranger things, then it can seriously harm. And Twitter being a text-based, although there are lots of pictures, but primarily a text-based platform, it is not a good platform for debate and try to persuade people about your point of view. So don't get involved in Twitter wars.
Especially in just several characters, right? So I agree with there are certainly the benefits of this, but I think what's the old adage about the amount of energy to refute bullshit is an order of magnitude bigger than that to produce it. You could spend your whole day kind of trying to debunk things on there. So,
okay, I think we're going to wrap it up here. I'd like to thank all our panelists for their time this afternoon, providing their wonderful insights into the clinical management of COVID. I want to thank all those who tuned in for this webinar, and I'd like to remind the audience that Part 3 of this seminar series is next week, same time, Ethics, Research, and Communication, December 17th. So if you enjoyed this session, please tune in for the next one. Thank you very much, everyone, for your attention and your comments, and we'll see you next time.